Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode is part 2 of a 12-part series entitled COVID-19, Answering the Questions. This series features brief updates on the latest incidents and clinical data related to COVID-19 diagnosis and management, each followed by an in-depth question and answer session designed to address infectious disease specialists' most pressing COVID-19 questions. During this podcast, Dr. Jens Lundgren from Copenhagen, Denmark, will provide a short update on the latest COVID-19 incidence trends, a concise guide to viral diagnostic testing, and new data on investigational treatment options. For more information on Dr. Lundgren and for a link to additional online education from CCO's COVID-19 Comprehensive Resource Center, please visit the show notes for this episode. Now let's get started and hear a brief COVID-19 update and answers to clinician questions by Dr. Lundgren.
Thank you, Jen, and good evening, good afternoon, good morning, wherever you are in the world. So I appreciate the opportunity to discuss with you some of the challenges we have in making sure we get a correct diagnosis of patients who is infected with this new pandemic coronavirus. So as you know, this is a pandemic, and the numbers continues to increase. The numbers that you can see here are obviously minimal numbers because a lot of the patients with mild disease, many of them are not really diagnosed directly, but are recovering themselves. And the other thing to say about this that focus mostly on Europe and the United States, although Brazil is there, as you probably have seen, the epidemic is really increasing on that continent at the moment, where it's sort of slowing down in Europe and the United States at the moment. So this just gives you that sense of that dynamic with an upswing in many places in North America and in Europe, and then a more recent upswing in several South American countries. Obviously, this is the first wave of the pandemic, and it may slow down, but with other pandemics, which are not really infecting a lot of people necessarily in the first go-around, if there is a slowdown in transmission, which is seen in Europe, for example, and in many places in the United States as well, we can probably anticipate that there will be a resurgence of transmission later on in the year or early next year. So I'm afraid we're not done with this pandemic in places that have experienced the first wave already. Now, the topic of today is diagnosis of COVID-19, and this is a tricky discussion actually, because it's not always easy to do. Sometimes it is actually quite easy, but many times it's more tricky, especially if you get a negative PCR result, which was the question that you saw early on that was discussed there. Now, some key sort of general points around laboratory testing for SARS-CoV-2 in suspected symptomatic human cases, and that's really important that we're now discussing patients who have symptoms similar to the case you just saw earlier, where you want to really focus your diagnostic skills around detecting the viral RNA by these amplification techniques using RT-PCR. And certainly, as many of you was alluding to, one or more negative results do not rule out the possibility of the infection. Remember that the factors potentially leading to a negative result in a person who is indeed infected with the virus is either because you have a poor specimen quality, you haven't actually swabbed the nose or the tonsils or the pharyngeal backside sufficiently intensive, so you essentially the virus hadn't had a chance to be absorbed on the swab. Timing of specimen collection, and here we separate the discussion of relative to symptom onset. So when we talk very early, we talk about a patient who either have no symptoms but have been exposed to a person who have been infected, and where you do a swab, and that comes back positive, or just around the time and the first couple of days, maybe up to day 3 to 5 after symptom onset. So everything around COVID is always relative to day of symptom onset. So very early in the first couple of days, as opposed to late, which is the typical patient that comes into the hospital, typically with the COVID pneumonia, typically on day 6 on average, maybe a little earlier, maybe a little later. But that's the sort of late patients coming in, and then obviously moving into intensive care patients around 5 to 6 days thereafter. So timing is really essential here in order for you to do the right diagnostic test. I'll come back and discuss that. Of course, specimens not handled appropriately, an obvious issue here. And if there is technical reasons inherent to the test, the viral mutations are a possibility. The virus is evolving. You may have seen already reports on that, that the virus is evolving. We talk about different types, genetically types of virus. But although I want to really emphasize here that although that there's been a lot of discussions around here about this topic, about viral evolution and so forth, at the moment we only know based on epidemiology and clinical presentation and course of the disease, there's only one type. But it just looks genetically slightly different from each other. But it may be, as the virus is adapting more to the human host, which is entered likely in November last year, that as time goes by, as more generations of people gets infected with the virus, that maybe there will be further viral evolution. So that's a very pertinent question and focus area of ongoing surveillance and research. Of course, you can have PCR inhibition, as you can see, with also other diagnostic tests based on molecular detection. So I guess the key point on the bottom right here is that if you have a negative result, and I mean, this is not specific for COVID-19 or SARS-CoV-2, I mean, that's just good clinical practice, right? If you have a negative result where you have a high degree of clinical suspicion of a disease, in this instance, COVID-19, then you really want to make sure that you do additional diagnostic workup. So don't be satisfied with a negative result, but press on if you have clinical suspicion. Now, IDSA have developed a sort of an algorithm, you can say, for how to think about this, which really is maybe a little bit more complicated way of saying what I just said here. If you have a high suspicion of COVID-19, what is that? Well, that's if you have a patient typically who's living in a community where you know that there's ongoing COVID-19 transmission, or a patient, of course, that lives in a place where there's not a lot of ongoing transmission, but who have been recently traveled. And you remember the incubation period for this infection being between 3 and maybe 10, maybe 12 days after exposure. So it's that sort of time duration we're looking for. If they are not hospitalized as opposed to hospitalized, that's the big issue here, because early on after symptom onset, the virus, if the patient is sick from this virus, it should be identifiable in the upper respiratory tract. There is tons of virus in patients around the time of symptom onset. So if you get a negative result back, it's probably because something went wrong in how you technically did the swab or how the specimen was handled. On the other hand, we have seen in people who are hospitalized, typically people who's coming into the hospital with the COVID pneumonia, that even a absolutely top quality upper respiratory tract swab procedure, everything is handled the way it should, that it comes out negative. And the virus is only identified once you actually do a tracheal suction and do examination on that. So essentially the virus is moving as the disease progresses away from the upper respiratory tract down to the lower respiratory tract and possibly into other organs. So it is not uncommon to see that patients have a negative swab from the upper respiratory tract but are critically sick. So in that situation, you press on, and you may want to continue to do another upper respiratory tract sort of sampling, but you also want to focus on the lower respiratory tract. And really only if this doesn't fit on the far right on the table, if this doesn't fit, either because you have very low suspicion, either based on epidemiology or clinical presentation, or that you have another very likely cause that explains why the patient is sick, and you get a negative result back, then maybe you should not really pursue this diagnosis anymore. And remember that COVID patients get sick from the infection itself, but they also get sick from like any other person. So also always remember your differential diagnosis. Now, this slide was put together by IDSA, try to sum up some of the data on the diagnostic sensitivity and specificity based on clinical sample collection. And it's probably the best data who's out there, although this data is accumulating quite rapidly. And there's some of the information here that I'm still a little wary around, but this is the result. And I think the key result here is if you find the virus, then you can pretty much trust that the patient is infected. That's really, so there is very few sort of false positive sampling, in particular in patients who is symptomatic. So if the test result is positive, then you can pretty much assume that the patient had the infection, at least that infection. Some of the issues is more about sensitivity, as I was just discussing, and also depending on which compartment you're sampling. It is a little surprising in this one that if you do a pharyngeal swab by itself without nasal swabbing as well, that the sensitivity was as low as it was here. We have to say, we initially in our clinic started off by doing a combined nasal and pharyngeal swabbing, and obviously the results were clearly positive. But we have actually moved away from sampling the nose because it generated aerosols, and we wanted to reduce that by the health professionals who was doing that. And so on the other hand, what's really instructing people who was doing the pharyngeal swab to do it very thoroughly and have maintained a high degree of sensitivity, and certainly higher that is displayed here. Quite interesting is saliva, because it seems like, at least in some studies, not this compilation of studies, but in some studies, there is also an ability to take high degrees of virus in that. And that would obviously be easier altogether if you just ask the patient to spit. Now, the other possibility, of course, is that you start to do other types of tests, and that may sometimes be necessary. Chest CT abnormalities can be used. Typically, the radiologist will come back and explain bilateral peripheral ground glass opacities and consolidations of the lung. It's typically seen, as I already alluded to, between day 6 and day 9 since symptom onset. And once you have seen a COVID pneumonia, also on a regular chest X-ray, not even a CT, you have seen them all because they look so much alike. So obviously this should heighten your suspicion level if you have that result back or you see it yourself on the screen. But remember that although it is very consistent in patients who are SARS-CoV-2 infected, there's a number of other diseases that can have a similar sort of picture. So remember, depending on whether the patient is severely immune suppressed or not, but pneumocystis, Legionella, and so forth, and even some places aspergillus look like this. But anyway, so that's a possibility. Now, just a very brief update before we go to the questions and the discussion. A little bit of an update on some recent disclosures of information. And the slides I'm going to show, I'm going to run through quite quickly. They're only based on press releases, not publications, which is why you may not have seen them. But I'm just showing these slides to get you aware of data who are potentially coming into the scientific literature quite soon. The first result was comparing 5 days versus 10 days of remdesivir versus placebo. A total of little under 600 patients were enrolled, and you can see that patients who they were not terribly sick, they had pneumonia, but they were not terribly sick, had a PO2 of more than 94%. What was interesting in this study, and also I think a little bit surprising, is that their primary endpoint was improvement on this typical 7-point ordinal scale at day 11. You typically want to move your primary endpoint away from the termination of the infusion, because obviously the 10-day dose would have an advantage compared to the 5-day dose for this particular endpoint. But that, I guess, is the way that they chose to design this. I should also mention that, there was a trial that you probably have seen published recently in the New England Journal of Medicine that was comparing 10 days for remdesivir versus standard of care, which showed a clear benefit in favor of remdesivir for patients who had moderate disease, as in here. Using the time to recovery endpoint in a little over 1,000 patients. So I guess that's already been established. So this study is studying a smaller number of patients, but is comparing to standard of care. So I think, although the primary endpoint is a little bit sort of surprising to me, there is sort of the same trend that standard of care patients did a little worse compared to patients who were receiving either 5 or 10 days. The comparison of whether you should use 5 or 10 days, although this data is not suggesting a strong difference, there was also a recent paper published in the New England Journal that came to the same conclusion. I think that the debate around the duration of antiviral treatment in patients with moderate, and in particular patients who have severe COVID-19, is still on the debate. Whether you can do stratification, like, for example, 5 days if people are not that sick, and if they're recovering well, you can sort of terminate it. But if they are very sick, maybe, I'm not saying that's what you should do, but maybe you should extend the duration. And I think there's some ongoing research which will hopefully clarify that. Now, the other trial, just to give you an update of that, and maybe some of you have seen already the press release on, was from the UK, the recovery trial. Like everything in the United Kingdom, it was done extraordinary, thoughtful. So this took a lot of different interventions that has been considered, including lopinavir, ritonavir combinations, low-dose steroids, hydroxychloroquine, and azithromycin, and we're comparing them to no additional treatment on top of standard of care, which, as you know, until recently was really symptomatic relief medication. What was interesting with this press release was that they essentially terminated the hydroxychloroquine arm because there was no difference in the primary endpoint on day 28. This was a large study, 1,500 patients receiving hydroxychloroquine compared to a little over 3,100 with the standard of care. but there was no difference in mortality. If anything, slightly higher in hydroxychloroquine arm, something we have seen a little bit of a trend as well in other studies. And there was also no evidence of benefit for duration of hospital stay and other sort of more soft endpoints, you can say. So it's going to be interesting to see that report once that comes out, because obviously this particular medication has been discussed so extensively in recent time, and we absolutely need randomized trial results to further understand that. The other trial that came out recently that is published in the New England Journal, focusing on hydroxychloroquine, looked at it as a potential post-exposure prophylactic intervention. So after exposure, but before symptom onset, where the endpoint was COVID-19 symptoms. And also there was a little over 800 patients in that study. And also in that setting, there was no benefit, no reduction in risk of developing COVID-19. Whether this will be the end of the drug, I don't know. I know that there's a number of randomized trials ongoing still. I think that will further sophisticate and give us an insight into whether this is still worthwhile. So, yeah, that was the spiel, Jen.
Great. Thank you, Dr. Lundgren. Sorry to interrupt you at the end there. We have had a number of questions, and that was a great presentation to introduce. And so now we'll get to the questions and try to get through as many as we can. So the first question is, Susan asks, if a patient has a negative nucleic acid amplification test by PCR and is positive for IgG, is that consistent with exposure more than 8 weeks ago, or would you not rely on the IgG by itself for that timing?
Well, it is probably because the patient has been infected previously. So that's probably what you should do. There is a little bit of cross-reactivity I've seen, at least in some of the antibody tests with other coronavirus, that sometimes make the result positive without the patient actually being infected. But that's probably how it is. Yeah.
Okay. Great. All right. And the next question is from Linda, and there's a similar question from Jody. It's basically asking if there are any reliable data to demonstrate whether or not patients are infectious if they have the COVID-19 antibodies. And are you concerned that that may be giving false assurances regarding immunity?
Well, certainly, I think that's a good point. But in terms of infectiousness of people who have COVID-19, we know that people are infectious before they develop symptoms. So in the pre-symptomatic stage, 1 to 3 days before symptom onset, people are typically infectious. We know that some patients remain asymptomatic, but is also infection at some unspecified time duration, maybe 5 to 7 days. But if you develop symptoms, you're obviously infectious while you have the symptoms. And then many places now would argue that probably 48 hours after the symptoms are resolved, then you can, for clinical purposes, assume that patient's no longer to be infectious. Some places that do PCR as well, after the symptoms have resolved, many of those patients will continue to be PCR positive, maybe 1 to 2 to 3, sometimes 4 to 5 weeks. We're really not sure whether that means and it is implying that there's still live virus. It's difficult to culture and identify as live virus, and it's probably resemblance of viral RNA that is still detectable by the PCR. So at least in my setting, we have stopped doing that because we just delayed people entering society, and we're using this pragmatic rule of 48 hours after the symptoms has been resolved. And don't rely on the antibodies. That's not going to be useful for that purpose.
Great. Okay. So this question, the next question is from Foster, and it also relates to, you mentioned about asymptomatic carriers, and it's related to a controversial issue right now because the WHO came out yesterday saying that asymptomatic carriers transmitting is rare, but the patient may just be pre-symptomatic. And so sort of the difference between asymptomatic and pre-symptomatic, and what are your thoughts there?
No, but I mean, that's the big debate here. And again, as I just said before, we know that in the pre-symptomatic phase, 1 to 3 days before you get symptoms, if you later on develop symptoms, you are most likely infectious, which have practical clinical implications, because anybody you have been together with and you are close together with are therefore potentially exposed, and therefore you want to do contact tracing for those. So you want to tell those you are close to 1 to 3 days before you develop symptoms that they have probably been exposed and therefore should be handling and reacting appropriately to that. Now, for those who remains asymptomatic, so you detect at some point, you detect the virus, but the patient never developed symptoms. Clearly, those people exist. How many it is, and how long time the virus is replicating, and whether they have a different sort of immunological response to the infection compared to those who develop symptoms, in my opinion, is still up for grabs. It exists, that's for sure. I would not want to put a quantity of how many of the total number of infections that remains asymptomatic. It probably, at least partially, depends on the age of the person. So probably you see this much more in younger people compared to older people.
Okay, that's very helpful. And someone asks, how do you manage those cases? And I'm guessing it's not.
Yeah. Really... So I mean, if you for one reason or another is doing a diagnostic test in a person who is not having symptoms, and the test results come back positive, then you want to isolate that patient, right? I mean, that's what you want to do. You don't know what will happen thereafter. And therefore you want to recommend that patients to be isolated so they don't infect other people. And then you will have to see how it goes. So if they develop symptoms, you know what to do. If they don't, you want to do a follow-up swab probably after 5 to 7 days and see whether the virus is still there.
Okay, that's very helpful. Okay, we have a lot of questions on this topic. This is from Jason, who says he runs a large community health center that has a dedicated COVID testing site. Currently, he only tests his staff if they are symptomatic. He wants to know if he should change his practice. Would you recommend weekly testing of all frontline medical staff? And he wants to also note that he now has greater access to testing.
No, I appreciate that. I mean, that has been the dilemma in many places, that there was some limitation on testing capacity. But I would argue if you don't have an issue in terms of ongoing transmission among your colleagues, I wouldn't do testing except if people develop symptoms. But if there is an outbreak, and I have to say I've seen many places now where there's been nosocomial outbreaks that affects both patients as well as personnel, typically because there was not a high enough suspicion that patient could actually be having COVID, sometimes because they came in the pre-symptomatic stage, and therefore have been able to infect 10, 20, maybe up to 30 people, both personnel and colleagues, as well as other patients. So in that situation, then of course you need to do a proper epidemiological investigation and swab everybody. The same is true if you have an outbreak in a nursing room that's well described as well. That's what you want to do to make sure you understand who is actually infected and make sure you handle that outbreak. Thank you.
Okay, that makes a lot of sense. Then there's contact tracing really too.
Yeah, okay. Contact tracing is really important here in an institution, either at a hospital setting, nursing home, or other places. So maybe that would be a topic for a separate Q&A, because that's a complex area to handle.
Yeah. Okay, great. So now we are having some other questions too that are moving into the treatment strategies. And so a couple of participants, including Bernard, Jana, and Eliza, have asked, when do you decide to initiate anticoagulation and for how long? And what is the importance of heparin?
There we go. I mean, that's a great question. I don't think anybody can give you a straight answer based on evidence. There is, as we all probably, if you follow literature on this, you'll appreciate that there is a thromboembolic complication issue with this disease that I have to say, I've seen a lot of infectious disease. I'm really surprised to see. We saw it a little bit with HIV, but this is massive. In particular, people who have moderate and, by far, and people who have serious COVID-19, people in intensive care. In terms of what is the best strategy to prevent these thromboembolic events in these patients, and that I really want to focus on patients who was admitted to the hospital with moderate to severe COVID-19. I wouldn't want to charge people with mild disease in this, because I don't know what I would say to them, and I may do more harm than good. But for those who submitted at the moment, what we do is that we give them heparin 1,500 units as sort of thrombosis prevention if they're outside of intensive care, and the double dose if they're in intensive care. I don't think that's enough. I know that there is a trial being designed at the moment to provide really solid evidence for that. So I think that would be one suggestion, but I know that there's other protocols as well, but that's at least how we do it in my case.
Okay. Yeah. So we definitely need more data there, but there's a starting point. Again, several participants, a couple people have asked a similar question, Jody and Stephen. What is the current data on the efficacy of convalescent plasma?
Well, I don't know. I mean, there's not a good study to really inform that question. I think the issue, not to downplay plasma therapy, but I think the issue that is coming through quite clearly is that obviously is obtained from a person who has recovered from an infection. But we know that different people mount a very, very different antibody response, including what we're interested in, of course, is neutralizing antibodies. So a plasma that you infuse may come from a person with high titers, may come from a person with low titers. And for those who high titers, they actually fluctuate over time. So that may not be an approach to treatment that we really want to pursue in the long run, because there's likely going to be more standardized products available where there's a defined neutralizing titer to really understand whether passive immunization is helpful in the management of acute COVID-19. So I guess that's what I'm betting on.
Yeah, that does make a lot of sense from a practical standpoint. A couple more treatment questions. Bernard and Eliza ask about systemic antibiotics, azithromycin, cephalosporins, efficacy, timing of their use. Any useful information there?
I have to say, when I saw my first COVID patients, I thought they must have a bacterial superinfection like we see in influenza, right? I mean, that's the typical situation in influenza, that they get a bacterial superinfection on day 4 to day 6 after symptom onset. We have been looking for that, and it's not like we haven't seen it, but I'm surprised they really get sick from COVID-19, and we can't find a bacterial superinfection. That does mean that we not many times I think feel like we need to cover the patient from bacterial infection because they're critically sick and maybe we have overlooked something. But many times administered empirically, we stop it again because it has no demonstrable benefit, and all microbiology comes back negative. And then of course you can ask, so which type of antibacterial agent to choose, and since I don't know what is the most likely, I don't know, but I probably want to cover the gram-positive cocci. So we give meropenem for patients who submitted with serious disease as sort of the standard.
Okay.
But there can be other arguments. So I'm not wedded to that. But,
I see. Okay. Okay, great. A couple of participants are also asking, and you talked a little bit about this in talking about the simple study, but this timing and duration of remdesivir,
Yeah.
5 versus 10 days, moderate versus severe disease.
Yeah, I think that's really only for the future to tell. So I didn't want to. I mean, I know for a fact, because I've seen it now, that people who have severely impaired B and T lymphocyte function, they can have COVID for weeks. Typical courses for maybe 2 weeks, maybe 3 weeks, but they can have it for 4, 6, 8 weeks because they essentially cannot mount an effective immune response. And maybe there would be a benefit for longer treatment in those patients. At least we have some small sample size to suggest that. But there's also the issue, if you look at the publication in Act 1, that there was no abundantly clear benefit in people who entered the trial on ventilator. Except if you look at the mortality curves, there is actually a trend, if you really want to look, in the first 10 days, which was the duration of the remdesivir. So I don't know. But that's a good question, and it's being pursued. But I don't have any evidence to share. Maybe you could go off for 5 days, as being suggested.
Okay. Some more to come there. We have a question from Mark. Is there any new information about COVID-19 in patients with HIV?
Yeah, there's actually an accumulating evidence base. I just was on a call earlier today with HIV senior scientists from around Europe. And I think the collective impression is that there's actually not a problem, except, of course, if you are just newly diagnosed and have complete severe immune deficiency as a consequence of that. But the well-treated patient with HIV, that has been doing well, fully suppressed for his HIV and have recovered his CD4 cell, they're good. I mean, they're not good, but they're certainly not worse off than people without HIV.
Yeah, that's good. So that seems to be holding that.
Yeah, that seems to be holding. That was the impression that we all had.
Okay. Okay, great. Okay, it looks like there have been several questions on tips for outpatient clinics and patients that are being treated at home. Any suggestions or any thoughts on treatments in the pipeline or doing at-home anticoagulation therapy for those patients? And I'm guessing part of this may be that in that setting, you can't do an IV drug.
Yeah, no, I think that's sort of outpatient treatment in people early on in their disease, which may be at higher risk of being admitted. That's an intense area of discussion. Is there a window of opportunity for us to dampen viral replication and therefore reduce the risk of them actually developing moderate COVID-19? And there's a lot of interventions being considered there. Most at the moment, the focus is on passive immunization. Whether it works or not, I don't know. In terms of home treatment for anticoagulation, that typically in the scenario that people have recovered from moderate to serious COVID-19 and then discharged. At that time, we actually discontinue anticoagulation. That may or may not be wrong, be right, but that's what we're doing.
Okay. There's another question about other antivirals. Someone asked if you think there might be any utility of favipiravir or unifimavir that are.
Maybe. I should be honest. Probably not. At least that's the sense that maybe, probably not. But of course, we don't know because they haven't been properly studied. So, I saw a lot of those questions on the question and answer section, but unfortunately, they haven't been studied. I mean, as you can probably gather, there was a fairly quick consensus that remdesivir could actually work. It's been developed against other coronaviruses that had the potential of actually working, and that turned out to be the case. So,
right, as opposed to influenza antivirals. Okay.
Correct.
Great. We have a question from Anthony saying, well, I agree that many of the antibody tests are low quality. There are some excellent serologic tests available that are done in CLIA-certified high-complexity labs. If you do have access to high-quality serologic tests, do you see any benefit to testing for antibodies in that case?
At the moment, I mean, it's interesting from an epidemiological point of view to understand how many, what portion of the population was infected. For that sort of thing, I think it's important. I know that people have been curious if they did not do a PCR test while they were sick, did I have the virus? So that sort of curiosity, which may be fine to satisfy with serology test. But I think the critical issue is, do a positive serology test mean that you can now relax because you had it and you won't get it again? And of course, that question we don't know because we haven't had a second wave of the virus. And therefore, we don't know whether there is a degree of protection, and if there is a degree of protection, how big is that degree in terms of getting infected again? We know in the short run, it's probably protecting that makes sense because the immune system was obviously able to control the replication to begin with. So there is some degree of immunity early on, but how long time that is maintained after half a year, I don't know. So for that reason, I would really be, at least I'm saying to people, don't use the antibody results for pretty much anything because you don't want to change your behavior. You want to keep distance and be careful with your hand hygiene and so forth, and don't trust that you're protected. So also my colleagues, you need to use your personal protection gear like anybody else. Also, despite the fact that you actually had a documented infection early on, because we don't know whether you are actually protected or not. Right. Maybe that question will be different in a half a year.
Right.
I don't know. But for now, that would be my best advice.
Yep. We don't know yet. Okay. Yeah, exactly. Oh, a lot of people are, so I think I'm going to try to do two more questions if that's okay, Dr. Lundgren. I think
sure.
We'll be at time. So a lot of people are asking some very specific questions about what you would say are the most accurate PCR assays or antibody assays. And I'm just not sure if that's something that,
sorry.
Yeah.
It's very setting dependent, and I really, you want to seek expert advice in your setting, because there will be people who know what they're talking about. There's a lot of people who don't know anything, and it's going to be very comfortable saying a lot of things. But if you go to the right expert, they will tell you what you need to know in terms of which assay to choose.
That makes sense. Okay, and then this last question I just think could be really helpful. This is someone seeing COVID patients in an outpatient office where CT is not immediately available. And so they just ask about if you could review the use of plain films. Are you able to see those?
I have to say, we stopped doing CTs because just the infection control management of people going to the CT was too complicated. So we actually have started to use regular chest X-ray, and they're perfectly fine. You don't need with a CT to understand that they have COVID pneumonia. There's typically no effusion, so there's no pleural fluid to look for. So the only indication I have for CT is in case you are suspecting a pulmonary emboli.
Okay. So. Great. Okay, that's very helpful to know that. Thank you very much, Dr. Lundgren, and thanks to listeners for joining in. As a reminder, to view the COVID-19 Comprehensive Resource Center on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.